So we're going to just walk through. We discussed about adhesive mechanical retention. We've talked about cord packing. We talked about drying. So let's just see it all in kind of in action. So we have our dual cord technique. We have our compression cord, the triple O, and deep in the sulcus. We could have placed that before we started preparing. We could have placed it before we complete our finish line, or after everything's done. We're going to leave that cord in during the impression. And then we have our deflective cord, which we need, like we discussed, need it in there to be approximately for 4 to 6 minutes to ensure we have adequate horizontal increase in our sulcular width. And we're looking for greater than 0.2 millimeters of horizontal sulcular width. So go ahead. Some folks leave the tails out. Some folks pack them in. I mean, it's up to you. We're going to peel this out. Remember, so one of the tips I was taught, when you remove this, make sure the preparation is wet. It just seems like it's natural to dry everything and then get ready and remove the cord. Well, when you do that, imagine you have a wound and you have a dry gauze on it. You pull that off, it seems to stick to it and actually open the wound again. So perhaps keeping everything wet may decrease the possibility of having a hemorrhage. Another tip that I was taught was remove it slowly, because if you do start having some hemorrhage, you can place another astringent and then pack the cord back into the location there. So we're going to remove our cord, like Dr. K says. We're going to practice many times, rehearsed with our tip, making sure we're going all the way around the tooth. Make sure, if you can, use 2 hands just to make sure you can have one continuous go around the tooth. Like Dr. Dre says, keep on the gas, stay on the gas. So we're going to remove our retraction cord while it's wet. I'll just do it quick. Now we have we're using as large a deflective cord as possible. In this case, we're using number 2. Using the larger the cord, perhaps the greater the increase in sulcular width you'll obtain. Now what we're going to do, because some of the materials, if you're using ferric sulfate, they may inhibit the set of your impression material, so we wash this really well. Use our air water syringe. Wash. You can use air and water to really cleanse this whole region. And then dry. Strict air all over the place. If you are using a dry angle, you may have to replace it at this point, or place the dry angle in at this point. That's probably the better time after you've completed drying. And then get your dental assistant, if you have one, to go ahead and what I normally do is wait until I say go. So what we're going to do now is take our light body and go around the tooth. And then I say go to my dental assistant, who is me. And they start placing the impression material onto the tray, or custom tray, or dual arch. Now, in this technique, what's suggested is to express some of this not onto the tray, but onto a piece of paper or whatnot, just to make sure that the beginning material may not be fully mixed. So we made sure that our adhesive is dried. And you can see how it's starting to come through those perforations. Perhaps if I place the adhesive on the perforations, it wouldn't be coming through. Alright, there's that. And now the same thing with this, with the light body. Just going to express some somewhere. Everything is dry. Now we're just going to go around the tooth, and we're going to just keep the gas. I'm trying to keep the same angulation. Now everyone has their own technique. By no means am I saying this is one way, but this seems to have worked. Some folks will stop and take air and use their air water syringe and blow that into the sulcus. And also, if you're trying to capture the contour of the adjacent teeth, I would recommend doing that, say for an anterior. Some folks suggest capturing the occlusal surfaces of, if you're using a custom tray, of all the teeth with a light body. That's one technique. So then we've told the patient, we've tried this in previously. Now just bite down and hold. And then that's it. So we'll come back, we're going to wait the appropriate amount of time, have a timer on, either your watch or an actual like a kitchen timer, and we'll wait the appropriate amount of time for this to set. Alright, so it's been 6 minutes, the beeper just went off, and that's we'll just get the patient to open. Okay, there we go. Now so this is a really important tip that Dr. K has taught us. Say for example, we feel, it's more of an intuitive thing, feel that, well, I wasn't really happy with that impression. I think that maybe I need to retake it, or perhaps it's every impression is important, but perhaps you're doing multiple units, say several units, and instead of taking the impression out, looking at it. Now, I was in dental school, one of the biggest things was don't look at your impression, take care of your patient. Perhaps in this situation, don't look at the impression, put it aside, check to see. So we'll take our impression out with a gingiva. You can see how the undercut, so that's that tearing that I was talking about, and just dryness of the teeth. I didn't talk about the dryness, but the tearing of that material. So in this case, you can see that some of the cords, so say this is you've already planned to do 2 impressions, and when you take the impression, as the impression is setting, it's maintaining that sulcular width. So instead of stopping and looking at your impression, and you already planned to do another one, check to see where the compression cord of this triple O has come out of the sulcus. Take it out. Go ahead and dry quickly, and if there's some hemorrhaging spots, possibly use air to stop the sort of the air pressure, as an idea of placing pressure onto that bleeding spot, hemorrhaging place, and then go ahead and get ready to take another impression. That's sort of another tip that he does. It seems to have worked out fine. And then here's our impression that we've just finalized. Let's see if we can zoom in there. And what we're looking for, and because this is a dentiform, we didn't get much plastic, rubber, sulcular width. This is that sulcular width. You can see it's a decent width there. Hard to measure without calipers. Pretty thin there. Decent width there. And we've captured the entire margin. So looking at our magnification to ensure that you have all the margins and any voids, and at times becomes an opinion where if a void is here on the occlusal surface or on the axial wall, whether or not that's a significant defect or not, and that comes with clinical experience. So then now we just finished provisionalizing, and then that's it. So we went through a number of tips, discussed sort of some of the ideas from literature, the textbooks, some of my residents and mentors, what their tips were. I'm just looking for the good old sheet. Let's just check off, see what we got. We got stay on the gas, 2-cord technique, remove retraction cord, take it out wet, synchronize with your dental assistant, dry everything, make sure it's all dry. Didn't have a third one. Dry best as possible. Keep everything ready in front of you. Dry the tray before 5 times, or try the tray before. Check the bite. Pick a contact in the anterior, on the opposing, on the adjacent. Make sure that the patient is, so the tray went in on the right side. Make sure that you've picked a place where they're going to be occluding, or close to MI as possible. And rehearse, plan with your dental assistant, dry well, and 2 cords. Okay, so that's a quick overview of impression capturing and sort of discussion along with those final impressions. Cheers.